Okay, hello everybody. Good afternoon. We're now going to talk about PET-CT in prostate cancer, so we're going to have a look at this. Now, it's not just going to be PSMA. I'm going to talk a little bit about some of the other agents that we use as well. So I'm going to start off with very simple stuff, sodium fluoride. And then we're going to talk about sort of metabolic agents, which include FDG primarily, a little bit about other agents that we use. And then receptor agents, obviously we do have PSMA, but also bombesin with PET, as against with SPECT that we discussed earlier. So this is an ancient image. This is how we did bone scanning. Well, I didn't do it, even it's too old even for me. But 20 years before I started nuclear medicine in the 1960s, we didn't have technetium 99M and generators. So to do a bone scan, we'd inject the patient with sodium fluoride, F18 sodium fluoride, and then we would do the scan on a gamma camera with a big heavy collimator. And this was the kind of image that you got. They're not PET images, obviously they're just single photon using the gamma decay from the PET radiopharmaceutical. Clearly, however, if we actually use a PET scanner, instead of getting that awful picture, we get much better images. And this is from a paper by Alvos Alavi in Pennsylvania, University of Pennsylvania, and he was comparing MDP and sodium fluoride. So he's using the MIP image from the sodium fluoride to compare across to MDP. And you can see almost instantaneously how many more focal areas of uptake you see on the sodium fluoride than you see on the MDP. However, you'll also note that you get rather a lot of non-specific uptake. For example, the ends of the ribs are all very hot on the sodium fluoride, but these are not metastases. But you could use the CT component if you have PET-CT to help work out what are mets and what are degenerative change. Evan Sapper, who works in Leuven in Belgium, also looked at this with 44 patients with prostate cancer, and they were all imaged with technetium MDP and then fluorinated sodium fluoride. And 23 of these patients were found to have metastatic disease. And the sensitivity of planar bone scans with the final diagnosis was 70%. SPECT increased that to 92%. Sodium fluoride found all the sites, but with similar specificity. It was a little bit worse with the bone scan because it didn't come with a CT, whilst with sodium fluoride there was a CT to help you read what was happening. Now, as we said before, not unexpected, because we do get sodium fluoride uptake in almost any bone abnormality, including things like arthritis. So this is a image from one of their studies. So here we have a bone scan, and the patient has a bit of a scoliotic spine, but there's nothing very much. But when you look at the SPECT study, which is panel B, there's a suggestion of some metastasis. But when you look at the PET-CT, you can see very clearly a nice focal uptake due to a metastasis. So it is better, though. The reason we don't do it is primarily cost and PET camera time. If we all had 4 or 5 PET scanners and sodium fluoride was the same price as MDP, we will probably do this as the standard technique. This is another one from her paper. There's a bone scan which does have a suspicious lesion up here. Those smart diagnosed the patient's got a pacemaker. And there's some update down in the pelvis. What is it? It's not so clear on the CT scan. It could be degenerative, but with the PET-CT, you can clearly see there's uptake, and that's in the site of an osteophyte. So that is not a metastasis. So you can be quite happy that the uptake here is due to degenerative change. However, here in T12, there's a focus that you're just not seeing on the bone SPECT CT here, but you can see it on the PET CT with sodium fluoride. So the good news is the pelvis area is not metastatic. The bad news is the uptake in L1 is metastatic. So this is one of our patients that we did some sodium fluoride on, and this is a patient who has got to the level of L5 two hotspots on their sodium fluoride scan. But when you look at the CT, in fact, one of them is due to an osteophyte, and the second one is due to a little osteoid osteoma. You see, it's very well circumscribed. It's not a typical metastasis. So what about metabolic imaging in prostate cancer? Well, the most common metabolic agent we have is F18 FDG. And many people say, well, it's not positive in cancer of the prostate, but that's not entirely true. About 15% of carcinoma of the prostate do have uptake of FDG, and you have to just be aware of that, because there may be many patients who have got more than one cancer, so they may have uptake in sites of, for example, in the bones, and is actually from the prostate cancer. So you just need to be a little bit careful before you say, well, anything that's FDG avid can't be prostate cancer. We do also see focal uptake of FDG in primary prostate cancers. And as you know, if you see focal uptake within the prostate, you need to report that so it can be further investigated. And there is a subtype of prostate cancer called small cell, and these are often FDG avid. So I think that we just need to be aware that FDG is not always negative in prostate cancer. And here's very typically, this is a patient who's scanned for a completely different reason, but here we have in the prostate, in the marginal zone here, we have focal uptake of FDG. Now that may not be a prostate cancer, but it needs to be investigated, and we normally would recommend that such a patient starts off with a PSA, and they may need to go on to have an ultrasound and biopsy done. So this is quite a busy little slide. This is from some work that was done in, I think it was in France, Burgrade, and they were looking at FDG uptake within the prostate and comparing that to something called the Gleason score. So the Gleason score is a measurement that's made on the pathology of the prostate cancer, and the more malignant the prostate cancer, the higher the Gleason score. And in a Gleason score of above 8 is nearly always likely to become metastatic. And what they were showing is that of all the measurements that you could make, various things to do with what you can see. So IPFU stands for intraprostatic FDG uptake. So where you got IPFU plus, you can see that that's more common in those here in 70% of those patients are Gleason score 8. Whereas if it's negative, 80% of those patients are Gleason score 7. So FDG avidity within the prostate seems to be quite a significant prognostic value in terms of determining these patients are likely to metastasize. And here again is there's some illustrations from the paper that they produced. And you can see that, for example, you get quite intensive uptake here in the left side of the prostate. And then the patient is given anti-hormonal treatment, and they improve. So that's another good measure that this is actually prostate cancer. And in C, again, there's a bone metastasis. This patient is treated with anti-prostate medication, one of the hormone castration drugs. And not only does the FDG improve, but you can see that the lesion becomes a bit more sclerotic And that's one of the issues, is that quite often when you treat patients, their lesions become sclerotic on CT. And it says here the PSA in the pre-castration scan was 125 and dropped down to 1.5 afterwards. So that's FDG. What about some other traces? So these are just really done for interest. So C11 acetate. Now, acetate is another one of these small amino acids, not amino acids, fatty acids. So where tumors like fatty acids more than sugar, and they include most of the prostate cancers and things like HCC, these kind of agents may be better. And there's a Japanese study showing that the C11 acetate was found in all primaries, but FDG in just 15 out of 100 patients. So as we said, this is where we get the figure of 15% of prostate cancers are FDG avid, but all of them are C11 acetate avid. Now they can look at local nodes, but the problem with C11 has got such a short half-life, you can only really look at part of the body at any one time. So it's not really useful for staging the whole patient. So this is from the paper, and you can see here we have the difference between FDG and C11 acetate. These images are not attenuation corrected, so they do look a bit weird, but you can see that within the prostate, you've got significant uptake of C11 acetate at the site of tumor. And this is one of our patients, and you can see here that this patient has a PSA of 3, so that's suspicious for prostate cancer. And the patient had a DWI MR, and the red arrow points to the on the ADC map, which is the way that you display the DWI. And you can see here that there's increased uptake on the left side of the prostate. And then when you do the C11 acetate, it confirms uptake on that left side. And if anything, the resolution of the PET is actually better than the MR DWI. And that's not unusual, because DWI is a very good technique, but it has poor resolution. Choline is another fatty acid analog, but also is increased in cell wall provision. So choline was our first technique where we could really look beyond the prostate. Originally started with C11 choline, but then you could only look at the pelvis. So more recently, people have moved on to F18 choline, which allows more of the body to be imaged and better for looking for metastases such as bone. And there's a paper from Buscombe et al. On this. So this is an image of C11 choline. And this is quite an interesting image because you have different diseases on either side of the prostate. So you have low grade uptake in benign hyperplasia and more intense uptake on the left side in the site of prostate cancer. And you can pretty much divide the two. So if the SUV is above 2.5 at 20 minutes post-injection, then almost certainly is a primary prostate cancer. But you can't really image the whole body with F18 with C11 choline. You just don't have enough half-life. So other people have developed F18 choline. This is an image from the University of Stuttgart, and you can see here uptake within a hemi side of C2 up in the cervical spine. We do at my present hospital in London use C11 choline quite a lot, partly because we have more patients than we can have access to gallium-68 dosed PSMA, but we tend to limit it to patients with no metastatic disease. So the next idea was working on amino acids. So we've done sugar, we've done fatty acids, now we're doing amino acids. And there's this artificial amino acid which goes under the name of fluciclovine or fluorocyclobutamine 1-carboxylic acid, if you want to know its chemical name. Now, the advantage of this is that early after injection, it has very little urinary activity, but it doesn't really stay within the tumor. So you really need to scan the patients fairly quickly after injection. And the first images were reported in 2016. And these showed that you could find metastatic disease with this technique. Now, as you can see, this is 2 different patients. The patient 1 has disease in the groin and axillae, and you can see there's a lot of lymph node disease, and in fact, it's also got lymph nodes in the neck, all of which are due to prostate cancer. And the second one has disease in abdominal nodes. There is a bit of urinary activity, but less than there is with some other tracers. This product is available, particularly in the United States, and has been very successful there until recently, when PSMA was licensed, and people now tend to be moving to PSMA. So let's talk about PSMA and receptor imaging. So this is prostate-specific membrane antigen, also known as the glutamine cyclopeptidase, and it's basically part of the folate system. So folic acid and folate are required for cell division. So cells that are dividing require to be able to take in folates. So the cells that want to divide, and they tend to be cancer cells, tend to have more of these receptors on their surface. Now, the only problem with using the term prostate-specific membrane antigen is it's a membrane antigen, but it's not prostate-specific. In fact, it's present on lots of other cancers, including particularly breast and pancreas. However, it is present on prostate cancer in the majority of patients and in the majority of their lesions. And interestingly is that when you give a chemical castration with one of these drugs, such as abiraterone or enzalutamide, then it upregulates the PSMA. So it actually makes the study more sensitive. So again, a bit like the dotatate, the first paper came from Germany, in this case in Heidelberg. And Heidelberg, to some degree, have been the leading center for PSMA. And they looked at 37 patients with elevated PSA. And they found the PSA level of 2.2 was the cutoff between being able to find half the patients to all the patients. I think as we've learned to read the scans better, that number's come down a bit and is now closer to PSA of 1. Originally labeled with gallium-68, in some places labeled with F18, and there is a licensed F18 in the United States at the moment. So this is the sort of the nubbins of the whole thing. So you've got this transmembrane receptor, and this part here is the folate receptor, and this can be attached by any kind of ligand that has this sort of folate structure to it. And then there tends to be as a linker molecule, so there's different versions. PSMA 11 is the one that's been used mainly in Europe for therapy, and PSMA 617 is the one that's been primarily used in Europe for diagnostics. There is another German one called PSMA INT, standing for imaging and therapy. And this one seems to have a slightly lower normal liver and urinary activity, and may well become a sort of second generation agent. And some people are using this around the world. This is one that's been popularized by Richard Baum, for example. So here we have a picture from University of Pretoria, and here we have a very nice uptake in a primary site of tumor on the left side of the prostate. And remember, we can see this with FDG, but we're going to be more likely to see it with PSMA. And obviously, we can also see metastatic disease with PSMA imaging, and we can see both bone and soft tissue. And that's important because patients who, for example, post-radical prostatectomy, their PSA may drop to 0, but when it rises, you need to find out where the disease is. And the earlier you find that, the more likely you are to be able to remove that disease, either by second surgery or radiotherapy. Well, as I said before, it's not specific. And there are a couple of things that are a bit of a pain when you're doing PSMA imaging. The first one is the pancreas is often very, very active. which makes looking up in the upper abdomen very difficult. And the second one is the very annoying habit of PSMA to have uptake in ganglia. Now, this is a paper recently published which suggests that the fluorinated is less of an issue in ganglia than gallium-68. So here you got a set to the same patient image with both agents, and the top one where the arrow is pointed is a little ganglion, and that has uptake of the gallium PSMA, but you don't see it so much in the fluorinated one. So that may become less of a problem, but quite a few times we've been trying to work out where ganglion could be. And certainly if you've got disease in abdominal lymph nodes, trying to separate ganglion uptake from lymph node uptake can be difficult. So how does the choline that we talked about earlier compare with gallium-68? This was a head-to-head comparison with patients who have already had castration, either chemical or surgical, and they looked at different PSA levels. Now it's actually quite pale, this slide. I'm sorry, I didn't realize how pale it was. So just to let you know, this is the choline here, this is the PSMA, and this is not significant. So less than 0.5 PSA, 12% with choline, 50% with PSMA, which is good but not brilliant. It is significant. Between 0.5 and 2, and to be honest, a lot of our patients in that group, 36% sensitivity with the choline, 71% sensitivity with PSMA, again significant. Now, by the time you're getting into quite fairly high levels of PSA over 2, then there's enough tumor that the choline will also be positive. So the real area where PSMA will find tumor that you can't find by any other technique is really in that sort of 0.5 to 2 PSA group. Now, doesn't mean say you shouldn't use PSA imaging in other groups, but it becomes very much a unique agent in that level. So here is a couple of patients from their study. So here we have PSMA and choline, and this is a little para-aortic node, and you can see it's all actually, I said para-aortic, it's more than what aortic caval actually, aortic caval node, and you can see that it's positive on PSMA but negative on choline. So I said the next stage is this fluorinated PSMA we discussed earlier, and the agent that has been licensed in the United States is this agent here, which goes under the study name of DCFBC. I've literally no idea what it stands for, but you can see again the typical binding here. So this is the binding part to the PSMA, the folated type structure. And then you have a nice benzene ring on here that you can put fluorine on. So it's a very simple structure. And what we can see is that the fluorinated product tends to have less salivary gland activity, slightly less pancreatic activity, and reduced urinary activity, but it still has renal excretion. So the fluorinated product possibly has got some advantages over gallium. The difficulty is getting hold of it. And again, a bit like in the US, gallium generators aren't very popular because of the size of the cities and the difficulty of moving stuff around. And the fluorinated product can travel. If you have 2 half-lives, you can go 4 hours. Whilst in Europe, where things are much closer together, then the gallium seems to be the preferred method. So another fluorinated product is 1007. One got a suspicion this is the 1007th one they've tried. And this again was published fairly recently in the EJNMI. And the slight difference on this one is that it has some biliary excretion, but very little early urinary excretion. So for example, Here you can see on the MIP image very clearly the primary in the prostate with almost no bladder activity around it. And this is a large primary, and these are local nodes. So A and B are different patients. So there's a question, which is the right one to use? I think the right one to use is the one you can get hold of, basically. So what about that posh fluciclovine, which is used in the US? How does that compare with PSMA? There was a prospective trial published in the JCO 2 years ago with metastatic prostate cancer. And again, they used some cutoffs to look at what they think might be the best level of PSA. And they wanted to do the difficult patients. So the difficult patients are those, the PSA that's greater than 0.2 and less than 2, on the argument that everything seems to work when the PSA is over 2. And in 30 patients, there were concordant results, but in 17 patients, the PSA was positive, and in 2 patients, the fluciclovine only was positive. So this may depend on the fact that we know that some patients can be PSMA receptor negative, in which case other agents such as fluciclovine is useful. So where do we use PSMA imaging? Well, at the moment, there's very little phase 3 trial evidence, but this is increasing. So where we're getting increasing evidence is in pre-radical operative stages. So this is where you've got patients who've just been diagnosed and you want to know the extent of disease so that you can decide whether the patient should have radical curable surgery. And MR has traditionally been used, but we know that MR is not good when lymph nodes are normal sized. So here, PSMA imaging is proving to be increasingly useful. Also, in those patients who have small metastasis, they can have more radical radiotherapy post-surgery. Now, the next group is the way we got most publications. Now, this is where you've got a rising PSA. The patient's had surgery, maybe they've been given a chemical castration. The PSA was negative, and then it starts to rise. You've done the bone scan, CT and MR, and then you can't find anything. And here, the PSMA scan can be extremely useful in finding small volume disease. Staging known metastatic disease, obviously that's where most people produce their pictures, because they like to show multiple dots of uptake. Maybe clinically less useful, though we are starting to see people being staged and restaged with PSMA, for example, when they're having chemotherapy for metastatic prostate cancer. And of course, the exciting thing that I'm going to be talking about later on this afternoon is the theragnostic pair. And there is new data from the VISION trial on this. So this is a patient from Cambridge, 76-year-old man, PSA is 13, has uptake on the bone scan in the neck and the lumbar spine. So what's causing it? It's difficult to tell. Could be degenerative disease. We've got degenerative disease in the shoulder, but it could be a metastasis. Now, he was part of a study that we were doing, and that study included a PET CT with PSMA, and then they went on to have a PET MR on our PET MR machine. Now, the interesting thing is that unfortunately I don't have the image available, but the PET CT image was negative, and that was imaged around about 50 minutes post-injection. However, because PET MR is so more sensitive, the PET detectors of these brand new digital detectors, when the patient arrived on the PET MR scan, it was 2 hours after injection. And then when we did the PSMA, you can see here uptake at the site in the spine, and this was subsequently proved to be due to a metastasis. So one of the issues might be with gallium-based products is that we can't do this late imaging very easily. And we've been forced to do imaging at around about 45 or 60 minutes because of the short half-life of the tracer. Whilst if we had fluorinated product, maybe we could scan later, we might pick up even more tumor. So we talked about bombesin yesterday. This is a gastrin-releasing peptide regulator. It's found in pancreas, upper GI, and tumors including CA prostate. Now I'm going to talk about the PET side of it today. This is, I showed you this yesterday, this is the structures of the bombesins. The one that most of the work has been done in is AMBF, known as amber. And these are basically, again, complex structures which attach to the bombesin receptors on the surface of the prostate cancer cells. So in the US, as we explained before, they're very keen on copper because it travels nicely because of its long half-life. And you can see here, this is a patient with bombesin uptake here in the prostate bed. And again, you can see very small uptake of bombesin. And notice again the normal activity in the pancreas. So in 2016, some people tried to compare bombesin with PSMA. This is a Japanese study. And what they found was that in the majority of patients, PSMA did have more lesions seen than in prostate. And here you can see, again, very nicely, periaortic chain of nodes marked up in the PSMA scan, which you can't see in the bombesin. But there was a subgroup of patients who were bombesin positive and PSMA negative. And it may be in the future that we'll need two therapeutic agents, one which is labeled for bombesin and one which is labeled for PSMA. And this is another patient where you can see very nicely the tumor on the, in this case, they're divided top and bottom. So this is the bombesin and this is the PSMA. You can just about see the primary, but you can see it much more clearly here with the PSMA. So in 2016, they produced this image of the year from the website Art Mini, which many of you may use. And this is some poor patient that for some reason got an FDG scan, a sodium fluoride scan, a C11 acetate scan, a C11 choline scan, a gallium-68 PSMA 11 scan, and a bombesin, that's a gallium-68 RM2 scan. And you can see here completely different distributions of the traces. So FDG really negative, sodium fluoride possible, but they could be degenerative. Nothing much on the acetate. The choline, again, was fairly negative. The PSMA wasn't particularly interesting, possibly a node here and possibly a node here, but this could just be urinary activity. But the bombesin was very positive. So this is a kind of patient who has very little in terms of PSMA activity, but may well have bombesin activity. The other thing you'll notice is that PSMA, as we know, has a lot of activity in the salivary glands, and bombesin doesn't. But on the other hand, bombesin has uptake in the pancreas, which is more than we do with PSMA. So if we treat patients with high activities, we may expect problems with salivary glands in this patient, but we could have pancreatic failure with this patient. So the role of PET in CA prostate remains complex. There is a range of tracers that we can use. And sodium fluoride is useful, but obviously bone scanning still remains the classic. I'll talk about that in a minute. Yeah, maybe choline imaging may help us with some patients, and it certainly has been shown to work with some patients. But I think most of us really now feel that choline doesn't have the sensitivity that we want, unless the patients have quite a lot of significant disease. And in terms of PSMA and bombesin, we probably want to have both these agents, but we'll probably do PSMA first And if there is an uptake in sites of known disease, we might then want to go to bombacin. And of course, the key is the one that will lead us to the best treatment for the patient. Okay, now there was a question which I had. I'm just going to turn off the recording.